These rank and rankal, they promote tooth resorption. And osteoprotegrin, PROTEGRIN, it inhibits tooth resorption. It inhibits tooth resorption. So this is the entire homeostasis, how the interplay of factors occurs. But what is the most important prerequisite for any form of resorption to occur? The damage to the non-mineralized outermost covering, that is pre-cementum and pre-dentine. Okay, it's tooth resorption. If we talk about odontoclasts, which are multinucleated giant cells, they attach to the tooth surfaces. Okay. This is the multinucleated odontoclast, and this is the tooth structure. Once they are attached to the tooth structure by way of an intermediate molecule like osteopontin, they send out projections this is called ruffled border. Ruffled border. Okay. And it produces saucer-shaped resorptive areas on the tooth called O-Ship's lacunae. So these irregular saucer-shaped resorptive areas on the tooth structure, which are produced by the attachment of odontoclast, they are called O-Ship's lacunae. And they send out projections called ruffled border of the odontoclast. This is how the tooth resorption happens. Now we talk about various forms of tooth resorption. Firstly, external inflammatory resorption. Remember that EIR is a standard abbreviation for external inflammatory resorption. External inflammatory resorption. This external inflammatory root resorption, if we talk about etiology, then it is most commonly associated with trauma, traumatic tooth injuries, and the forms of trauma which are most likely to produce external inflammatory resorption are firstly avulsion, complete exarticulation, the tooth has come out of its socket, avulsion causes 30% incidence of external inflammatory tooth resorption. And then there are luxation injuries, which cause 5 to 18% incidence of external inflammatory resorption. Okay. Other causes of external resorption can be chronic apical periodontitis. But what is the most important cause? The most important cause is the trauma to the tooth structure that happens. And most common form of trauma is the avulsion, followed by luxation injuries. And also in cases of chronically infected periodontal ligament, chronic apical periodontitis, there are chances of external inflammatory root resorption. Okay. If we talk about clinical features of a tooth which is undergoing external inflammatory root resorption, then initially there are no clinical symptoms. Vitality testing of a tooth can be positive or negative. Ambiguous results are obtained. If the question is specifically asking you and giving you options like positive and negative separate, then you stick to the negative pulpal testing. Otherwise, In the strictest sense, if we talk about, there are no clear-cut pulpal indications for this in the initial stages of tooth resorption. When secondarily infected, when infected, there would be signs of pulpal inflammation. Okay. But there are no clinical symptoms initially. And I'm again repeating, if the question is specifically asking you what would be the pulp vitality response, positive and negative are given as separate options. Stick to negative pulp vitality response, because why? Because when we look at the etiology, then majority of the cases are related to avulsion of the tooth. If a tooth avulsion has occurred, then the pulp would definitely be necrotic. So pulp vitality testing response is negative. If we have to stick to one possible best answer. What are the radiographic features? Now, external inflammatory resorption is a very fast developing thing, and radiographically it is evident as early as 1 week. It can be evident as early as 1 week. General time during which it is evident radiographically is in the range of 2 to 3 weeks. So there can be two separate set of questions. Read the question carefully. How early it can be evident? It can be evident 1 week. Generally 2 to 3 weeks it takes to be evident. Okay, on this. What are the radiographic features of external inflammatory resorption? There is loss of lamina dura. One of the most conspicuous features is complete loss of lamina dura is there. Then there can be irregular cavities on the root surface that is seen radiographically. We know that there is resorption of the root, and that resorption is saucer-shaped irregular resorption, which is called O'Ship's lacunae. And there can be associated bone loss. If the lesion progresses, there can be associated bone loss. But one of the most conspicuous sign evident initially is loss of lamina dura. Complete loss of lamina dura happens in the areas of external inflammatory resorption. Histologic features. Histologic features, they can be seen after 1 week. Right? What are the histologic features? There would be the same histologic features that we have seen. We would see areas of resorption called O'Ship's lacunae. Okay. Attachment of odontoclasts is present over there. And irregular resorptive areas are seen on the external surface of the tooth. It is called O-shaped lacunae. Histologic features are there. Now, this external inflammatory resorption has a rapid progression. If it is unchecked and untreated, it can result in complete root resorption in as early as 3 months. In as early as 3 months, it can result to complete root resorption. So it has a very rapid set. So it is important that initially we identify it with a radiograph. But the problem is that initially there are hardly any clinical signs and symptoms, and the patient reports only when it is in an advanced stage. So definitely whenever the patient reports, we have to look for the signs of external inflammatory resorption and treat it on an urgent basis. Now, what is the management or the treatment for this condition? As the name indicates, external inflammatory root resorption. It is associated with pulp necrosis or degeneration in the advanced stages. So, what we have to do, we have to do pulpectomy. Pulpectomy to remove the infected pulp from the root canals. When we remove the infected pulp from the root canal, the inflammatory process withholds, is halted. Then, intracanal medicament. Intracanal medicament can be given. Intracanal medicament like calcium hydroxide, which has got potent anti-inflammatory properties, it can be given. CH stands for calcium hydroxide. And this is followed by obturation of the root canal. Obturation of root canal. Fill the area of resorption. Suppose this is a tooth root that has resorbed like this. And when we look at the root canal, it is a wide open canal. Regular obturation is not possible. After calcium hydroxide dressing, we can attempt epexification, that is closure of the root end by forming an apical plug of substance like MTA, that is 4 to 5 millimeter thick plug of MTA is formed, followed by obturation of the root canal. Okay. So basically what we have to do, we have to first remove the infected pulp, give an intracanal medicament for a week or two, and then followed by obturation. If the regular obturation is not feasible, we treat it as an immature pulpless tooth and do an epexification procedure with MTA or similar material. This is the clinical management of external inflammatory resorption. A reverse question that can come like, what is the most common sequelae of avulsion? टूथ एवल्जन का मोस्ट कॉमन सीक्वल क्या होगा? एक्सटर्नल इन्फ्लेमेटरी रिजॉर्प्शन. And what is the most common etiology of external inflammatory resorption? Tooth avulsion. Okay, this is the etiology and this is the sequelae of avulsion. Okay, and this external inflammatory root resorption is considered to be failure of avulsion. If at all ankylosis occurs after avulsion and replantation, it is considered the success. Okay, so there are different questions related to these. Read the questions properly and then answer them accordingly. This is external inflammatory resorption. Now we talk about another form of external resorption, that is ECR. ECR is what? It is external cervical resorption. Another form of external resorption is external cervical resorption. External cervical resorption is known by other names like invasive cervical resorption, supraosseous extracanal invasive resorption. What are these? These are the different terms which are used for external cervical resorption. Okay. External inflammatory resorption, or subepithelial inflammatory cervical resorption. These are some of the terms which are used for the same thing, that is ECR. ECR is a standard abbreviation for external cervical resorption, the most common term used for all these lesions. Okay. This external cervical resorption is basically considered to be a benign, proliferative, fibrovascular, fibrovascular, and fibroosseous lesion. What type of lesion is external cervical resorption? It is a benign, proliferative, fibrovascular, and fibroosseous lesion. And because of this, microbes have very little role. Microbes are really responsible for this form of external cervical resorption, external resorption. If we consider the external inflammatory resorption, then it is most often associated with microbial infection of the pulp cavity because it is inflammatory in this nature. On the other hand, microbes have a very limited role to play in external cervical resorption. If we look at the etiology, what are the causes of external cervical resorption? Although a definite relation between the cause and effect is not established as of now, but if we talk about the common causes, then from the most frequent cause to the least frequent causes, they are listed as orthodontic tooth movement. Most common, orthodontic force. The second most common is trauma. Third most common cause is oral surgical procedures. Oral surgical procedures. And another cause that is very less common is intracoronal tooth bleaching, which is also called non-vital tooth bleaching, isn't it? Non-vital tooth bleaching or intracoronal tooth bleaching. So if we look at the severity from the most common to the least common, these are the causes of external cervical resorption. Another set of questions that can ask you, what is the most common side effect of intracoronal or non-vital tooth bleaching? Then the most common side effect is external cervical resorption. But tooth bleaching is not the most common cause of external cervical resorption. So vice versa is not true. I hope you understand what I am trying to say. The most common side effect of intracoronal bleaching is definitely external cervical resorption, but bleaching is not the most common cause of external cervical resorption. The most common cause is orthodontic tooth movement. Whenever injudicious, uncontrolled orthodontic force is applied, there is development of a lesion called external cervical resorption. What are the clinical features? Clinical features, if we talk about hardly there are any symptoms. There are no symptoms and there is a positive vitality response. Okay. If we compare it with external inflammatory resorption, we have seen there would be a negative vitality response. Here there would be a positive vitality response because the pulp is not infected. Another clinical feature that is for is pink spot on cervical margin of tooth. Okay. If this is the tooth and this is the gums, there would be a pink spot on the cervical margins of the tooth. This is one of the clinical signs that is evident, pink spot. Do not get confused it with pink tooth of memory. There's a pink spot due to formation of fibrovascular granulation tissue in the cervical region, and this is evident during patient would not be having any symptoms. It is evident during routine scaling. The dentist would notice a pink spot on the tooth due to formation of fibrovascular tissue or granulation tissue. We have seen it is a benign proliferative fibrovascular and fibroosseous type of lesion. If we talk about histological features, and histologically two type of tissues are there. Granulation tissue, where that is fibrovascular tissue, and fibroosseous tissue in the lesion, bone-like tissue. So two type of tissues are found, granulation and fibroosseous tissue. Radiographic features, if we talk about, radiographic features, then there is a radiolucency in cervical region of the tooth. If we take X-ray of a tooth like this, there would be a radiolucency and the root canal outline would be visible through the defect. Root canal outline is visible through the defect is a diagnostic feature. Visible through defect. It is important to remember that this is one of the most important features of radiographically diagnosing that it is an external cervical resorption. The outline of the root canal would be visible through the defect. Okay. Second is we can distinguish with internal resorption by slob rule, that is buccal object rule. We all know what is the radiographic technique of Clark's rule, slob rule. Slob means same side lingual, opposite side buccal. So tube movement, when we take X-ray from different angulations, movement of the tube occurs, the lesion location changes with respect to the canal. With respect to canal. When we shift the position of the cone from mesially or distally, the location of the lesion with respect to the canal would also change. So these are the two things which help in distinguishing external cervical resorption. Now, what is the management of external cervical resorption? Then firstly, hand scaling is done. This hand scaling, it removes granulation tissue. And whenever granulation tissue is removed, copious bleeding would occur. We all know that granulation tissue is very rich in, because it is a fibrovascular type of tissue. The outermost area is fibrovascular area. There would be hand scaling is done. And then we do mechanical instrumentation. Mechanical instrumentation. This mechanical instrumentation is done to remove another type of tissue, that is fibroosseous tissue. Initially, granulation tissue is removed, then the fibroosseous tissue is removed. First step in the management, second step in the management. After these type of pathological tissues have been removed from the defect, the third step is application of 90% trichloroacetic acid. We apply 90% trichloroacetic acid on the defect. Okay. What happens with this acid? It causes coagulation necrosis. It causes coagulation necrosis of coagulation necrosis of what? Pathological tissues. So we have to understand the sequence of events that is happening. Firstly, we would remove the fibrovascular tissue by hand instrumentation, then the fibro osseous tissue by mechanical instrumentation, and whatever microscopic pathological tissues are left, that would be removed by application of a chemical that is 90% trichloroacetic acid. This causes coagulation necrosis of the tissue, and in the fourth step, it is rinsed off. And finally, the defect, because there is a cervical defect in the tooth, it is sealed with a aesthetic restorative material. We would seal the defect with aesthetic restorative material that can be either composite or GIC or RMGIC, depending upon the clinical need and the situation. This is how we manage the cases of external cervical resorption. Now, there are 4 grades of external cervical resorption. And these 4 grades of external cervical resorption were based upon the radiographic classification given by Heathersay. Heathersay classification. Okay, this is based upon the radiograph. So it is basically a radiographic method of identifying the severity or the grade of external cervical resorption. According to this, type 1 is a small defect in dentine only, not reaching the pulp. If we see the tooth, this is the pulp organ of the tooth. In the cervical area, there would be a small defect evident on the radiograph, that is type 1 external cervical resorption. Type 2, according to Heathersay, is a defect involving pulp and limited to the crown only. There's a defect which is involving them reaching the pulp but limited to the crown. So if this is the tooth, this is the pulp organ, then there would be an extensive defect almost reaching the pulp, but it would not be involving the root, limited to the crown. Type 3 is a defect that reaches coronal 1/3 of pulp, coronal 1/3 of root. It is another extensive defect. This is the tooth, the pulp organ of the tooth. There would be a defect from the cervical area and involving the coronal 1/3 of the root. And type 4 is one of the most severe forms. There's a defect that reaches deeper than coronal 1/3 of root. Okay, so if this is the tooth, the pulp organ of the tooth, then there would be an extensive defect of cervical resorption extending to the depth of the root. So basically, type 1 and 2 They respond well to the treatment that we have seen above. What is the treatment? The sequence of treatment we have already seen. Type 3 and 4. Okay. Because of their location, they are very difficult to treat and they require tooth extraction. And these classifications into type 1 through 4 is based upon the radiograph. The disadvantage of the Heathersay classification is that it is able to detect the cervical resorption in the proximal areas because we take radiographs. But if the defect is present on the labial or the lingual area, it is very difficult to detect or see its full extent. So this is external cervical resorption, the various clinical radiographic features, treatment management, and the Heathersay classification. So principally two forms of external resorption are there, inflammatory and cervical resorption. Now we talk about internal resorption. Internal resorption. This internal resorption is abbreviated IRR. These are standard abbreviations. IRR stands for internal root resorption. So in your questions or in your options, you can get these abbreviations as such because they are standard resorption abbreviations. This internal resorption is of two types, inflammatory and replacement. And as we have already seen, what is the prerequisite for internal resorption to occur? Damage to the inner non-mineralized predentine layer. You have to remember that the odontoclasts, the tooth resorbing cells, do not attach to the non-mineralized active coverings, that is the predentine and the precementum. Inflammatory, it results in resorption of pulp chamber, or we can say pulp cavity. Replacement, as the name indicates, replacement results in obliteration of pulp cavity. Obliteration of pulp space, pulp cavity. So these two type of internal resorption, they're different sequences, but the pathological condition is more or less the similar. The etiology is the similar. So firstly, we talk about etiology. Just like external cervical resorption, no clear-cut etiology can be designated for the initiation of internal resorption, but several reasons or the several causes that are implicated. Firstly, the most important one is trauma. Secondly, caries, carious lesions. Thirdly, there can be causes of cyst and tumors. These are the different causes or implications related to the etiology. The most common one is trauma that you have to remember. Okay. Now, if we talk about the clinical features, the clinical features, again, like other forms of resorption, initially there are no clinical symptoms. Patient would not experience any pain or anything. Later stages or the advanced stages, due to subsequent infection of the resorptive defect, there would be clinical symptoms like pain. Okay. What are the histological features? If we look at the histological features, then there's definitely formation of tissue metaplasia. Tissue metaplasia. What is tissue metaplasia? Transformation of the pulpal cells, pulpal progenitor cells, pulpal progenitor cells into giant cells that form tooth resorption. Now, because of trauma, there is damage to the predentine layer. Now you can see there is a slight difference in the origin. From where do these odontoclastic or multinucleated giant cells come from? They come from the tissue metaplasia. You know that dental pulp consists of certain progenitor stem cells also. Because of the impact of trauma and damage to the predentine, there is a change in the differentiation of these progenitor cells and they become multinucleated giant cells that start eating the tooth from inside. That is known as internal resorption. From where the external inflammatory cells were coming? They were coming from the circulating blood monocytes. Now this is called tissue metaplasia, transformation of the pulpal original cells into these odontoclastic giant cells. Now we talk about radiological features. If we look at the radiological features, there is a uniform enlargement of root canal. There's a uniform or fusiform enlargement of the root canal. Sometimes it is also called fusiform enlargement of the root canals. So if we take radiograph of our tooth, which is undergoing internal resorption, we would see some anatomy like this. There would be a fusiform or uniform enlargement of the root canal. An important distinguishing feature from external cervical resorption is that the root canal outline is not visible through the defect. This is one important feature which helps in distinguishing external cervical resorption from internal resorption. Another feature is that slob rule, if we apply, we make a radiograph from different angulations. The lesion position does not change with respect to the canal. In cases of external cervical resorption, we have seen that the position of the lesion changes as we change the X-ray cone angulation. So these are the two important radiographic features which help in distinguishing. Now, prerequisite for progression. Not for the initiation. What is the prerequisite for initiation of internal resorption? Damage to the predentine. What is the prerequisite for progression of the lesion? That is apical pulp should be vital. This is the coronal pulp and this is the apical pulp. Pulp apical to the defect. It should be vital, that serves as a constant supply of nutrients to the odontoclastic or the multinucleated giant cells which are resorbing the tooth from inside. The coronal pulp, on the other hand, remains necrotic, and because of these two things, because of the apical vital pulp, the lesion keeps on progressing. As soon as the apical pulp stump becomes non-vital, its blood supply is damaged, the lesion would halt in progress because the supply of nutrients to the odontoclastic cells would be cut off. So these are the two things that you have to remember: prerequisite for the progression and prerequisite for the initiation of internal root resorption. Now, this internal root resorption, when occurs in the clinical crown of the tooth, although it is called root resorption, it can occur anywhere in the pulp cavity. If it occurs in the clinical crown, it gives to pink hue to the crown. The crown of such the tooth becomes pink in color, and this pink hue is called pink tooth of murmur. Sorry, pink tooth of mummery or odontoclastoma. Okay, so do not get it confused with the pink spot that we have seen with the cases of external cervical resorption due to formation of granulation tissue. Here, the pink hue to the crown is given due to expanding of the pulp cavity, and the blood circulation comes very close to the external surface of the tooth. It gives rise to a pink hue to the tooth, sometimes also called pink tooth of mummery or odontoclastoma. These are the various clinical and histological features of internal root resorption. Now we talk about treatment or management of internal root resorption. Now, internal root resorption definitely requires removal of the inflammatory necrotic pulp. So pulpectomy is done first, then intracanal medicament. With calcium hydroxide is done. Calcium hydroxide, because of extremely caustic pH, is able to render all the odontoclastic cells inefficient. They makes it dormant. This calcium hydroxide dressing, CH stands for calcium hydroxide, and then it is followed by obturation of the defect. Okay. This obturation is done with a specific technique of obturation, that is thermoplasticized. Aperture method. We inject liquid gatta parcha into the root canal. So the question is asking which method of obturation is preferred for cases of internal root resorption or internal resorption simply. The answer would be thermoplasticized fluid gatta parcha method, because it fills the cavity very well as compared to solid forms of gatta parcha cones that we use for obturation. Sometimes what happens if there's an advanced case of internal root resorption? This can result in perforation. So an additional management required is sealing of perforation with MTA and similar materials. We have to repair the perforation followed by obturation with a thermoplastic obturation method, internal root resorption. Okay, only when the perforation occurs, we have to seal it with MT or similar materials. So these were the important aspects of the tooth resorption. So we have discussed what are the three forms of tooth resorption and how do we distinguish the external form of resorption from the internal resorption. What are the changes which happens? What is the normal pathophysiology? We have talked about the different cells, their origin, and histological as well as radiographic differentiation of external from internal tooth resorption. Okay. I think this is all about the important high yield effects of internal tooth resorption. One important point that we have to remember that I have talked about intracanal medicament is calcium hydroxide, which is routinely used for cases. Instead of that, one anti-resorptive intracanal medicament can be used. Anti-resorptive intracanal medicament means it inhibits the activity of odontoclast cells, that is leather mix based. Is better suited as compared to calcium hydroxide. So this is a better intracanal medicament, leather mix based. This ladder mix paste is basically a mixture of two things. One is triamcinolone, triamcinolone acetonide, which is a steroid. Steroids are anti-inflammatory, and dimethyl chlortetracycline, which is an antibiotic. Ladder mix paste. This ladder mix paste is an anti-resorptive intracanal medicament that inhibits the recruitment of odontoclast and prevents both the internal and the external form of resorption. So if there is a case of tooth avulsion, long-standing case of tooth avulsion, which is a preferred medicament, ladder mix paste. If there's a case of internal resorption, which is a preferred paste, ladder mix paste. So if the question is specifically asking you the intracanal medicament of choice, you would stick to ladder mix paste. Otherwise, calcium hydroxide routinely. With this, I conclude my today's session on tooth resorption. I hope it has been comprehensive enough. Please start doing the MCQs related to the topic. And my best wishes. See you again in the next session. Till then, very goodbye.